Okay, we are recording. Let's get this back up here. Excellent. Okay, so I heard liposarcoma. Why liposarcoma? And welcome, by the way, everyone online. We're doing fat, muscle, and bone today.
Liver fat, some fat necrosis, a little bit of cells, cellular.
So it's a fatty tumor. It's very hypercellular, and it has an arborizing chicken wire vascular pattern. So that at scan is very concerning for liposarcoma. Zonal areas of necrosis would certainly go with that. And then you look at higher power for the presence of lipoblasts, which can be Mulberry type lipoblast or can be signet ring lipoblast like this one here. Okay, very good. So keys are hypercellularity, arborizing vascular pattern, often described as chicken wire type of vascular pattern. Angiolipoma. So looks like an ordinary lipoma with some angio superimposed. Usually capillary-sized vessels, small vessels, and often with thrombosis. Very good. So piloleiomyoma, it is a proliferation of smooth muscle. You can see all of the vacuolization. Smooth muscle has to work for a living, so it always carries a little vacuole, a little glycogen snack in its back pocket for when it has to work so hard. And you go off to the periphery, and it is pointy like the spokes of a pinwheel at the periphery. So those are keys to a piloleiomyoma, and then multiple piloleomyomas tend to go with Reed syndrome, fumarate hydratase deficiency, and renal, not oncocytomas as in Burton-Hardie-Bay, but renal papillary carcinoma.
So it looks like maybe like a smooth muscle hematoma.
Yeah, so it goes on. You get a sense that this is something broader. This is a punch out of what was probably a broad plaque made of smooth muscle bundles, often associated with hypertrichosis and hyperpigmentation because it's all in a continuum with Becker's nevus. Good. Okay, something that's not from this chapter at all, but in the box.
Looks not good.
Looks not good. I'll agree with you there.
There's like a lot of mitoses. There's like some of them kind of line up, but a lot of bleeding in there.
Yeah, lots of bleeding, and in areas you have sort of crack-like spaces.
Okay, so like angiomas.
Like an epithelioid angiosarcoma, and this is after mastectomy and radiation. Those retrieves, which has a particularly dismal prognosis.
Accessory tragus.
Like an accessory tragus, except that this is midline of neck. So what is it? Just like in a turkey. A waddle. So people can have waddles just like turkeys have waddles. It's like an accessory tragus, but it's in the middle of your neck.
So in this area we cannot correlate tragus.
Oh, in that area, waddle.
Waddle.
Yeah. So tragus on the cheek, and wattle here, just like in a bird. Birds have wattles.
Kind of looks like a marble.
Like a red marble with vascular spaces.
Like
Angioleiomyoma. Yes. That is exactly what your brain said when your lips said something different. That is correct.
It is. This is like a big dermal nodule. I think it's like kind of ropey collagen. Okay, so it's bad. A lot of mitoses.
Lots of mitoses. If this stains for smooth muscle markers, what do you think about the cellularity of this tumor relative to normal smooth muscle?
It's much higher.
Yeah, much higher. So higher nuclear to cytoplasmic ratio, very hypercellular, mitoses present. So if
like
this is smooth muscle, leiomyosarcoma, correct. There are soft tissue people who want to call these atypical smooth muscle tumor because they don't tend to metastasize, they grow locally. But that's true for basal cell carcinoma, that's true for DFSP, it's true for lots of cutaneous sarcomas. So I'm not sure anyone in the dermpath world is buying it, and we still, I think, appropriately designate them as leiomyosarcomas. They don't have a high risk of metastasis, but certainly are aggressive locally. And they do have some risk of metastasis. Probably on the order of a DFSP or basal cell.
So this looks like I see fat and probably smooth muscle in there. Like an
Angiomyolipoma. So if this was one of multiple tumors in a kidney, what would your patient have? Tuberous sclerosis. But this is cutaneous, so it's probably associated with nothing whatsoever. Yeah. So the cutaneous ones are usually not associated with...
Sorry.
It's okay. The cutaneous ones are usually not associated with tuberous sclerosis, whereas multiple in the kidney are associated with tuberous sclerosis and frequently cause renal failure because of compression of the kidney. And they, especially the renal ones, fall into the pecoma category. They tend to be S100 negative, but stain with other melanocytic type markers, similar to pecomas in the lung in young women with a history of tuberous sclerosis. That's the progressive leiomyomatosis of the lung is a horrible, horrible disease in young women. Leads to lung transplant at a fairly young age. High morbidity and mortality, and is one of probably the worst consequences of having the tuberous sclerosis trait. And those are all in the pecoma group. Okay.
Oh, I see angiophlegmatic.
So first off, what's that component?
Is that?
Fat. So there's fat. And there's spindle cells, and there is also not as much in this example, which is I think why it's a little harder, but there is at least, here we go, at least some areas with ropey collagen. So the three components of ropey collagen, fat, and spindle cells, often with a myxoid stroma, spindle cell lipoma, So spindle cell lipoma, something that you'd expect to test really well because it's not controversial, but there's endless variety of the proportions of fat, ropey collagen, and spindle cells. You can have ones that are almost entirely spindle cell. You can have a lot of fat. You can have very little fat. Steve Billings described non-fat variant and low-fat variant. He set the threshold at 5%, took all kinds of grief because everyone knows low-fat is 2%. At least when it comes to milk, right? He finds that very funny when you remind him of that. But he actually did a beautiful job of fleshing out the variants that have very little fat in them and brought people's attention to it. They tend to be CD34 positive, so when they have little fat, you could mistake them for solitary fibrous tumor, DFSP, other things of that sort. Acral skin, vascular nerve bundles.
Accessory digit.
Yeah, supernumerary or accessory digit. Looks similar to acquired digital fibrokeratoma, but has bundles of nerve vascular bundles. Sometimes cartilage bone, sometimes it's like an entire digit.
It's like the fat's a little bit high.
That's a little high. What do you think?
Next one, maybe.
What do you think about the size of the adnexal structures?
Yeah, they're small.
Very small, like you'd find on an ear.
And there's a little bit of probably an accessory tragus.
Like an accessory tragus if this were cheek, but this again is midline neck, so this is a waddle. Patients find that very complimentary when you tell them they have a waddle. Fat, spindle cells. If we were to say there's some ropey collagen in here, then you've got spindle cell lipoma. Again, any combination of those features in any proportions, the fat, the spindle cells, and ropey collagen, often with a myxoid stroma. Angiolipoma, like a lipoma with all the little small vessels. Yeah. If this is smooth muscle leiomyoma, the very strange thing here is there's acanthosis and sebaceous induction like a dermatofibroma. Which is a little unusual. Angiolipoma, red marble with vascular spaces. Oops. I tried to make an escape.
Like a chordoma or...
Yeah, chordoma or chondroma. You want to know how mature it is. Does it have vacuolated phycoliferous cells? And where was it? So this was adjacent to bone. There were really no multivacuolated phycoliferous cells, and it was just a chondroma. Chordomas can look similar. True chordomas are axial, usually deep, like presacral type lesions, and are on a spectrum from benign to malignant, often with metastatic potential. Parachordomas are out in the skin. They're not true chordomas. Most of them are benign. They're in the myoepithelioma group, just along with chondroid syringoma, mixed tumor skin. So they're parachordomas look kind of like chordomas. They're myoepithelial, and they are in the spectrum of mixed tumor of skin. So again, true chordomas, metastatic potential, axial, deep, often presacral in location. We often see the metastases in skin. Primary cutaneous parachordoma is a myoepithelioma in the spectrum of mixed tumor of skin. Think of it sort of like a mixed tumor of skin without the ducts. Looks like a piloleiomyoma. What do you think about lymphoid aggregates in a piloleiomyoma?
Makes me a little more worried.
It makes you a little more worried, and then you'd look for hypercellularity. You'd also look for extent. This thing was a deeply invasive tumor, so it's a very well differentiated, not so hypercellular liposarcoma. I'm sorry, leiomyosarcoma, with the hint being similar to desmoplastic melanoma, having the lymphoid aggregates. Jen McNiff was always fond of saying that lymphocytes are better at identifying melanomas than pathologists are. Sometimes they're better at leiomyosarcomas too. So if the host response doesn't like it, pay attention.
Looks like them. Look how that's bone, like osteomycutis.
Yeah, like osteomycutis, and in this case, you have a little follicular cyst. It's like this sort of thing you get with post-acne osteomycutis. People feel like they have BBs all through their face or birdshot all through their face where their acne has left little osteomas. They're often bluish-gray in appearance. So you've got all these hard little bluish-gray things through their face. And you make a little stab wound, stick a needle in it, and pop it out, and it takes you all day to pluck out, and you end up with a urine cup full of little birdshot pellets of bone. But the patients are incredibly grateful for the care. I mean, basically you teach a nurse or tech to do it because it really takes hours to pluck them all out. But if you had them, you would want to get rid of them too. Let's see.
I see that. Mixed-way. What's in the collagen?
So you're thinking,
Spinocetic.
but I don't see any fat.
I think that's okay.
Yes, exactly. And in fact, there was some fat. So this is in the low-fat variety. But the myxoid tissue, the spindle cells, the ropey collagen, they're all very characteristic.
Looks like a lot of smooth muscle.
Yep.
I'm trying to decide if it's fat or not.
What do you think about the nuclear cytoplasmic ratio?
I think it's pretty high.
Yeah, and it's a little hypercellular. There are mitotic figures,
Yeah.
so that puts it in the leiomyosarc category. There are so-called symplastic leiomyomas, which is ancient atypia in a leiomyoma. So they're atypia, but no hypercellularity, no mitoses, and those are benign. So symplastic leiomyoma, akin to an ancient neurofibroma, has atypia, but no hypercellularity and no mitoses. So atypia by itself in a neural crest or muscle-derived tumor means very little. Hypercellularity, on the other hand, or mitoses, dictate behavior, or predict behavior, would be the better way to say it.
Looks like the fat comes up pretty
lots of fat. So what are you thinking?
Like nevus lipomatosis superficialis.
Like nevus lipomatosis superficialis of Hoffman and Zarell. Or Zarella if you're German, but Hoffman and Zarell. NLS tends to be Blaschkoid, segmental, often limb-girdle area. A skin tag can look very similar, but would not be Blaschkoid in distribution. And then the genoderm that can look somewhat similar is Goltz, where the fat starts to form in a perivascular location and eventually replaces the dermis. So even though the old name was focal dermal hypoplasia, it's really a neogenesis of fat in Goltz syndrome. Also in a Blaschkoid distribution, but at a young age, they look like red stria, atrophic stria, become yellow and outpouchy with time as fat develops, and then there are the associated features of a lethal gene. So whereas nevus lipomatosis is a normal width Blaschko segment, Goltz is always a very narrow Blaschko segment, as any lethal gene would be, because that tissue dies, right? And then the associated loss of digits, loss of eyeballs, jaw abnormality, all the various things that can happen.
It's fat. And lipoma?
Very pale. There's fat. There's spindle cells. There's rugby collagen. Spindle cell lipoma, again, part of the endless variation and endless fascination we have with spindle cell lipomas. So these are mammary ducts. So this is a nipple, but it is a very muscular nipple because it is a nipple leiomyoma. Right? So leiomyomas can occur anywhere where you get smooth muscle. So you can have piloleiomyoma, scrotal leiomyoma, nipple leiomyoma, and it's benign, but often alarming because it's enlargement and hardening of the nipple can be, become quite tender when the muscle contracts.
Dr. The nipple have a normal smooth muscle.
Nipple normally has smooth muscle, so it has to be dramatically out of proportion to the normal. I mean, that nipple was very large in size and is all muscle. So that.
Fat, see some blood, see some hypercellular.
And are the lipocytes all similar in size and shape? So ALT would look like fat at scan, with the clue being variation of size. This has a lot of spindle cell myxoid in the background and arborizing vessels, so probably more like a conventional liposarc. ALTs can be very subtle, but there the variation in lipocytes is your first clue that it is in fact a low-grade liposarcoma. Again, the soft tissue people prefer the term atypical tumor for anything that doesn't tend to metastasize, right, that has local growth. So they would call it atypical lipomatous tumor, but it's analogous to low-grade liposarcoma. Lacks the arborizing vascular pattern. Atypical cells are usually only seen around the septum. Your clue is the variation in size of lipocytes at scan, and then MDM2 and CDK4 are positive, and that's often done by chromogenic in situ hybridization or fluorescent in situ hybridization.
So, looks
Like maybe a piloleiomyoma, very cellular piloleiomyoma with lymphoid aggregates. Leiomyosarcoma. The hypercellularity being a clue. Let's see what else we need to do here. In fact, looks just like the prior one we had. I think it's another cut of that same tumor. It's in skin, stellate and spindle cells, and sort of very badly formed lacy bone. So sort of bad lacy bone throughout.
Osteosarcoma.
Yeah, exactly. So this is osteosarc metastatic to skin. So osteosarcomas, bad lacy bone, spindle cell tumor, sometimes myxoid.
Can we call it bad to the bone?
Bad to the bone.
Okay. Yep. Oh. Hold that one in.
Okay. So accessory tragus, you are correct, and this one actually was on the cheek, so it is not a waddle, it is an accessory tragus, but it has the very diminutive hair follicle similar to what you would see on the ear, and the cartilage, often fat present as well. Okay, so you're in the dermis, and it's very myxoid,
Spindle cell.
with ropey collagen and fat.
Spindle cell lymphoma.
So it's an intradermal spindle cell lipoma, which can in fact occur.
It's kind of like a piloleiomyoma.
Like a piloleiomyoma, what do you think about the degree of cellularity relative to normal smooth muscle?
It's kind of high right there.
It's a little hypercellular, right? So it's probably leiomyosarc. So atypia by itself doesn't mean much, but hypercellularity correlates with leiomyosarcoma.
Looks like we got a lot of spindle cells.
Lots of spindly cells.
Look like they're a little atypical. There's like a high.
Yeah, there's certainly pleomorphism. Some of them almost look like smooth muscle cells. So you'd worry about some sort of sarcoma down in the fat. And then presence of lipoblasts would lead to it being a liposarcoma. Soft tissue people often look at chromosomal translocations as well, because those help to define the tumors.
It's very cellular. Ropey collar, spindle cell.
And this one,
I thought I saw ropey collagen, but it doesn't look that good.
there is normal fat, and then tons and tons of little capillary-sized vessels. This isn't an angiolipoma, this is an angiolipoma, right? Just with a lot of angio to the angiolipoma, right? Just as with spindle cell lipoma, you can have any proportion of the vessel, and the ones that are likely to trip you up are the ones that are just very heavy with vessel. Like a leiomyoma, it is up in the superficial dermis like a piloleiomyoma, and it has points like a pinwheel out at the periphery. There is no hypercellularity, so that is a pretty good guess.
It's not very cellular.
Not very cellular.
Not, there's a little bit of fat, but not much.
And I'm not even sure I'm seeing fat. I'm
Okay.
seeing degenerative, like edematous areas.
It's well circumscribed.
Yep.
Can we see what the cells look like?
No.
No.
Because
Okay.
it's pattern diagnosis. So you have
Okay.
vessels. Where does that vessel wall, like where does this vessel wall end? Or does it not end? Does
It's
it
kinda
become the
crack-like
tumor?
spaces. Is this an angiomyoma?
It's an angioleiomyoma. Exactly. So the key is you have those vascular spaces, and then the smooth wall, muscle wall just becomes the tumor, is the tumor, be the tumor.
You don't have the angiomyoma or angiolipoma.
If there's fat, then it's angiomyolipoma. If there's no fat, then it's angiolipoma.
There's fat.
Just edematous areas. In that one. If you found a lipocyte, then angiomyolipoma.
Piloleiomyoma.
Looks like a piloleiomyoma. It's got that pinwheel appearance at the periphery. I think we covered most of the entities that we needed to in this chapter pretty well. So let's put those away and let's grab a potpourri box.
Dr. Olson, it's a little dim. I don't know.
Oh, a little dim.
Yeah, just a little bit.
Oh, I think it got turned down a
Sorry,
bit.
thank you.
Okay, thanks. Yes, don't suffer in silence. Okay.
Looks like a cell.
Looks kind of seborrheic keratosis like, except that it has melanocytic nests.
And I think it looks like benign.
Yeah, it's a benign melanocytic nevus. They often have seborrheic keratosis like horn cysts. Important because presence of horn cysts on dermoscopy does not make something a seb. It can be a nevus, it can be melanoma. So don't rely too heavily on presence of horn cysts on dermoscopy in terms of defining a tumor. Clue is that it starts to form this kind of cell.
Histocytosis, some kind of.
Yeah, so something histiocytic, and then those cells are starting to lipidize at the periphery.
JG?
Yeah. So even though this has many spindle cells, it is a xanthogranuloma. It tips its hand with the formation of the wreath and two-ton giant cells.
Doctor, what are those holes?
The lidocaine.
Injection?
Oh.
Injection?
Yeah, injection of lidocaine. Anything that's firm, you have to press hard to get the lidocaine in there, and it forms little vacuoles. Just tells you the lesion was sclerotic.
It's kind of Paisley-tie-ish.
Like Paisley-tie-ish. So what's your differential for Paisley-tie?
More fearful is a cell, serum donor, there's plastic tracheal F,
One
No, no,
50-year-old
yeah, no.
microcystic adnexal carcinoma. So, and this one, where would you put it in that group?
BCC.
Yeah, probably basal cell, and some might say this is micronodular. It has, these small little nodules that in 3 dimensions are worms that worm their way through the collagen. So how well do you think you could define this lesion with a curette, with curettage? Not at all. Your curette just slides over all of that reticular dermis, so they are often much deeper in extent than your curette tells you, which is why they have a high recurrence rate and more aggressive.
And that's usually a disposable curette.
If you use the sharp side of a disposable curette, you can go straight to bone if you try.
So it looks like we're kind of hanging off epidermis. Doesn't it have a thick basal?
It does not have a thick basement membrane zone.
Right, so I don't think it's trichomoma.
Agree, it's not a trichomoma. What kind of...
Are those? I mean, they're vacuolated cells.
Yeah.
Bowen's disease, maybe?
So vacuolated cells like Bowen's disease. What else can have vacuolated cells?
Like a clear cell or CCA.
Or
Sebaceous.
sebaceous.
Yeah.
So if this is a sebaceous tumor, you might look for what kind of associated things, Muratori in the family. So, find out if there's gut carcinoma or other features for Muratori syndrome in the family.
Dilated pore.
Yeah, like a dilated pore of Weiner. If there are multiple of these, it could be part of Dowling-Dego's syndrome. I heard that. If it looks like multiple SEBs. If solitary pore of Weiner, but you should whine when you say it. Let's see. Weiner. Overlying epidermis attenuated or acanthotic?
I guess that's
So maybe dermatofibroma. The collagen balls are present at the periphery, and the acanthosis is present over, so dermatofibroma would be a good bet.
Paisley tie. Looks like BCC.
Paisley tie, and this is, whereas the last was micronodular, this is more what most people would call morpheoform, where the islands of basal cells become just one cell thick, and most of what you have is sclerotic collagen. And they really look scar-like clinically, but expanding.
So there's some kind of large, unusual looking cells in the dermis. Yeah, they kind of have that what is it, reticulohistiocytic.
So they have a two-tone cytoplasm similar to reticulohistiocytic. Reticulohistiocytic, do they normally give you nuclear pseudo-inclusions?
No.
Nuclear pseudo-inclusion goes with what?
Spits.
Yeah, melanocytic, and this could be a very epithelioid Spitz or a spitzoid melanoma would be your differential. So, nowadays it would be probably a fast road to CGH or NextGen to see, does it have the genomic signature just of a Spitz nevus, or does it have additional mutations like a Spitz tumor with more melanoma type potential.
So very cellular dermal proliferation. Looks like they're kind of like multinucleated.
Yeah.
Like
In fact, you have ringed lipidized siderophages all through it,
so
and overlying acanthosis. So this is dermatofibroma. Ringed lipidized siderophage is pathognomonic for DF. The acanthosis overlying the spindle cell proliferation is a very helpful clue. Adnexal tumor. What
Sweat,
bucket?
Looks like it's sweat.
Looks like it's sweat.
It's malignant. Do you want blank on
You have a branching alveolar pattern of ducts.
They say that you talk about mixed tumors.
So, and this, in fact, is mixed tumor. It's well circumscribed. It's not particular hypercellular. The ducts have the same cellularity that you would have in a normal apocrine duct. So just benign mixed tumor of skin. When they're malignant, there's usually proliferation and increased density of the ducts. It's usually the duct portion that becomes malignant.
very broad shave.
Broad shave.
A lot of inflammation in superficial tumors. That looks like a little basal cell.
Looks like a basal cell. In fact, there are buds of basal cell here. And then your stroma gets very sclerotic and red, right? That's often a clue to a more aggressive pattern of basal cell underneath. So you want to look very carefully with the keratin stain and see what is there subtle morpheoform BCC under.
Dermal nodule. It's pretty superficial and small. Kind of spindled cells.
And you have all these clefts in there.
Not sure.
So has a little bit of a little fine capsule at the outside. In some areas, these line up in little palisades. Yeah, palisaded encapsulated neuroma, and the clefting between the fascicles is a very helpful clue for palisaded encapsulated neuroma.
So it looks like a spindle cell.
Could be, or could just be fat, right? And then the question is that fat necrotic, or is it varying in size like an atypical lipomatous tumor? So you want to look a little closer. And then you have all of this proliferation with the red blood cells and microvesiculation within the stroma, like liposarcoma or like nodular fasciitis occurring at a site of trauma with fat necrosis. The red cell extravasation would be pretty good for nodular fasciitis as a clue.
So shave and acanthosis.
Acanthosis, actinically damaged skin, and then in the center you lose your actinic damage. It's eosinophilic. There's even a little hint of fibrin there, and then granulation tissue on either side. So like a acanthosis with a column, like chondrodermatitis nodularis chronica helicus. Very good.
So Professor, PS go deep to fat like nodular hashtags. PS.
Oh, Kaposi's. So Kaposi's, not likely deep in fat. Something that would look like Kaposi's in a child deep in fat, more likely KHE, Kaposiform hemangioendothelioma. One of the clues is also Kaposi's tends to be nodular. This thing spindled out into the septi. So the outline is not like KS. The outline is more like nodular or proliferative fasciitis.
Nevus.
Like a nevus, and then right in the middle of this nevus, you have this area with heavily pigmented melanophages and then small hyperchromatic nuclei with a smudged chromatin pattern and inconspicuous nucleoli. So could be melanoma or could be deep penetrating nevus type change in a benign nevus, so-called common combined nevus of Reed, where you have DPN like population together with benign banal nevus. This one.
Regressing KA.
Like regressing KA, it's very sebaceous though. And this looks like it's kind of bumpy. It's broad. I don't see any hairs. So maybe it's broad, bald, bumpy, and bubbly, like a nevus sebaceous of Yadosome.
So there's pigment in the dermis, and then it looks a little sclerotic.
So give me
centralized.
two things in the differential.
So melanocytic.
Yeah. So what kind of melanocytic things have a sclerotic?
Desmoplastic melanoma.
So desmoplastic melanoma and
Can spits be sclerotic?
spits can be desmoplastic, but what else? Blue nevi. So the question is, are you looking at a piece of a blue nevus, or could it be desmoplastic melanoma? You can do Key 67, look for lymphoid aggregates. That one ultimately blue nevus.
Okay.
But if there's any question, make sure it's out. I don't think that one's fair. Okay, let's do this one.
So acantholysis or herpes.
Yes. Herpes, you see multinucleation, molding, and margination of chromatin with ballooning degeneration and acantholysis. So that is in fact herpes. So when you see necrosis of follicular epithelium, you think of zoster. In this case, though, the follicular epithelium isn't really necrotic, but you do have suppurative and granulomatous folliculitis. What are causes of suppurative and granulomatous folliculitis? Yeah, could be bacterial, could be fungal. In this case, in other sections, it showed the infected hair of Miyake's fungal folliculitis. compact hyperkeratosis, attenuated epidermis, a little bit of pigment incontinence, homogenized dermis, lymphoid band, lichen sclerosis. Very densely homogenized so that it looked a little scar-like. Oral mucosa, evidence of morsicaccio, so it's been chewed upon.
There's acanthosis, there's blood. Could be like a little fibrous.
Yeah, submucosal fibroma, benign submucosal fibroma, and you just can't help but chew on them.
Looks like cyst, and it has the red sharp tooth border, so
Steatocystoma, very good. Shark tooth border.
Very cellular. At the scan, I was thinking about this. Oh no, it's on chromo. Is it chromomycosis?
Well, I don't really see pseudoepitheliomatous hyperplasia. I do see plate-like acanthosis.
DF.
So probably dermatofibroma at scan. It does have a lymphoid aggregate. I would go look a little higher. I would probably put an S100 or SOX10 on it just to be sure it's not desmoplastic melanoma, just because of the lymphoid aggregate.
So, just like little pieces of spindled cells, smooth muscle.
Looks smooth muscle. And this was a nodule on the scrotum.
it's a scrotal myoma.
Yeah, benign genital leiomyoma.
Hanging off the epidermis, there's like blue cells.
What are all of these things?
Are they squamous eddies?
They are squamous eddies.
So this could be like a squamous cell carcinoma.
Squamous eddies are more common in squamous cell carcinoma or in irritated seborrheic keratosis.
Irritated seborrheic keratosis.
Yeah, the whole thing's probably just an irritated seb. Looks almost like an everted rather than inverted follicular keratosis.
So it's a basaloid neoplasm.
Pink strands, blue buds, horn cysts.
Pincus? It's the infundibular cystic.
Yeah, exactly. So if it's more anastomosing, it's a pincus. If it's more radiating, it's infundibulocystic BCC. They're both forms of basal cell. So if you call it one versus the other, you're not going to hell for either one. Either one's fine.
Interface change.
Yeah, interface change. And is it lichenoid or vacuolar?
Vacuole.
So it looks like your basal layer is still intact, just everything's shot full of holes. There is atrophy. There's a patchy lymphoid infiltrate. Thoughts? What kind of things give you hyperkeratosis with a vacuolar interface dermatitis? MF if you had a lymph in every hole, and papillodermal fibrosis.
Okay.
Drug, BLK, early BLK. Syphilis would be in a differential viral drug, and then connective tissue disease. And this one was a patient with lupus.
Dr. Elston, is anything else going to have the basic memory zone that day? 'Cause that was like a 6F almost.
I don't think it's actually the basement membrane zone as opposed to just papillodermis.
Okay.
You can see it's collagenous.
Oh, okay.
I guess basement membrane zone technically is collagenous too. Uniform, not individual fibers.
Cascading tie.
Yeah, Paisley tie differential. So there is solar damage there. So what is your Paisley tie differential?
Morpheo-MAC.
So morpheoform BCC.
Plastic tribe. So maybe this one is BCC.
So most likely this is basal cell carcinoma, maybe microcystic adnexal carcinoma because of the associated solar damage. Less likely to be syringoma, less likely to be desmoplastic trichoepithelioma. Cyst with lots of keratin, and then in the wall of the cyst. Like a dermoid cyst, there are adnexal structures in the wall. Let's do one more, and then I think we're there.
Split. Eosinophilic. So BP, EBA.
So bullous pemphigoid, EBA, don't forget arthropod, especially bullous scabies in the differential. But you'd want to get immunofluorescence. So subepidermal split, many eosinophils, pemphigoid, epidermolysis bullosa acquisita would be your most likely, and this one was BP.
And scabies
Well done.
can have an IF positivity, can't they?
Scabies can have an IF positivity, which is